through the CRA formula. For this one, we did not, but obviously it's an issue that needs to be considered. And my thinking was, as he was mentioning, that this affects the costing of the health sector, but it affects all the other sectors, isn't it? So yes, health is becoming more expensive, and so is maybe infrastructure. There are many counties with roads that are unpaved or whatever. So it's a larger issue than just human health resource, but it does affect how much then should we give. For example, when you're costing how much goes to counties, are we considering, first of all, have we established an optimum, first of all, so that we can say, let's give more to Elgeyo Marakwet for having less health workers? You understand? So that's an issue we have to deal with first before we start saying, now let's give more because it's becoming more expensive, right? So it does affect, but I think it's a bigger issue than just human human resource. And it also speaks to the issue of is it possible to leave it to the market itself, labor? Is it possible to leave it to demand and supply, for example, so that counties are able to respond to their needs? All right. So it's not coming at this level where we're saying we think your needs are this, but the counties themselves are able to put in either financial or non-financial incentives to attract health workers. So there's also that flip side that we have to consider. Yeah, we are aware of the EDA, and someone asked, am I aware of an act that distributes health resources particularly? I am not aware of an act. We can keep digging. I wasn't digging, but I can say now I'm not, as per now, I'm not aware of an act like that. But I also feel like for EDA, because it distributes development funds, they run to the same problem where now people want facilities, but like you said, at what point do people say, now we want health workers? Because the Equitable Development Act 2015 is about development expenditure, isn't it? So that's also, but I know they're amending the act, they're in the process of amending the act, and maybe it can take into consideration such things. Yeah, did I come across data on within county distribution? I did not come across data between 2014 and 2017. What I saw is for like a county like Turkana, they're planning to hire more, and they're giving specifics on how many for example, how many doctors per this is what I said, per sub-county. So I think counties are thinking about it because that's what they have to grapple with. How do we then distribute these 4 doctors that we want to hire? So I have seen it's not being done 1 doctor per sub-county. It's being done at a different, distribution. So counties are considering, I would say that for Turkana, but like I said, it's something that we need to look into more. How are we distributing resources within county? Yeah. I don't know if there's anything else that was raised.
So I think I'll answer your question and yours together, probably. Yeah, your question was whether we go into, looking at, like the animal side and other things that will probably determine the disease burden, for instance. I want to point out that, in terms of data analysis and looking at data, there are 3 levels. We have the descriptive type of analysis where we're just saying that, like if you went in the first interface that I showed you, just shows that these are the numbers that happen in this place. And then we go into the second level where we're talking about predictive, and that is exactly what we're doing at that point, that we are putting in more than one variable and doing a prediction. But, we are hoping now as we go on, and with many inputs, we are now going into the prescriptive level of the data analysis, where then we're saying that while we predict A, B, C, D, but when we bring others, we can now do a prescription. Then we can say that, for this kind of thing, this is what you want to do. So we are coming there, but we are still really at the predictive level. In terms of the data, for example, the KDHS, I think for us, as we move on, things are getting brighter because, if you look at the DHS portal, for a long time it has been more of a repository, just you go in and pull in data. But if you look at it now, they are moving into an interactive way. They have what we call the APIs, the application programming interfaces that we can link with. So what we're doing is that as we continue developing, we will develop hooks that will harvest the data that we need. And so our tool, the difference between us and probably maybe other people is that we don't do data repositories. We don't repository data. We just look for good data, run it through our engines, and give you things that you can use. Yeah. I think those are the two questions that are.
Good. Thank you very much. I would really love this conversation to continue, but I must bring it to a close, partly because we need to continue to other things. But I'm suggesting we change our program just slightly. So we were to have 2 presentations, then take a tea break. I am suggesting we take the tea break right away for 15 minutes only, please, strictly so. Then when we come back, we will have a presentation from our colleague from Kemri and from Edwin. Again, very interactive conversations, and then Dr. Alex will lead us in a more in a panel session, basically to discuss a bit more details thereafter. And then within an hour, we should be coming to a close. Would that be agreeable? Good. Let's take a health break. There is tea provided at the other end. In 15 minutes, let's come back. Thank you very much.
Otherwise, and even because it's HDMI, I can just run it from my comp.
Sorry?
I can run it from my comp.
I think so, but
But can you just do it here anyway?
sometimes makes life easier.
Yes.
Yes, so the title remains the same. So yes, the issue. So this is actually a continuation from what we started last year.
Yes, yes. So we decided instead of starting a new lineup and they will all these documents will be on the same website, it actually makes sense to just have a chief. Yeah, yeah. So that's where the numbering goes. Sorry, I think I had not explained that. I just put it in the first one. That's the logic. Alright. Alright, sir. Thanks. Yeah, so the other one I checked, the tables now are all okay. Okay, sir. Okay, sir. Yes, sir.
background of the requirements for universal health coverage. So, universal health coverage, we've probably heard about it. We've probably discussed. Okay, I think I'm loud enough. Is anybody? Can you all hear me? Yes. Okay, I'll project my voice a bit more. Maybe I'm not used to these gadgets. So, universal health coverage. You've heard about the UHC box, and the idea basically is there are two dimensions there are two things to look at. So when you're trying to assess the extent to which you're progressing towards universal health coverage, then you're looking at either the proportion of the population that's protected from financial catastrophe, financial risks when accessing care, or you're looking at proportion of population covered with good quality health care when needed. So that's service coverage. So I want to present some recently published work around assessing the first plane, and then after that I will talk about the need for the second plane, even as we're discussing health financing reforms and so on and so forth. So Kenya is in a fortunate position, as you all know. The need for the plan for UHC has actually been written in the health policy. So we know that Kenya has the political will and has already committed to achieving UHC by 2030. I think it's a main objective in the Kenya Health Policy 2014, and we know that it's actually also there must be speakers somewhere. It's also entrenched in the vision, in the national vision. Yeah. I think it's some feedback from the to that. Okay. So let me see whether this will work. That's a challenge that we face actually. You may implement certain, like you may scale up insurance coverage, but the poorest are not able to access that insurance coverage, or they're not able to access the facilities, even if they have insurance subsidies and so on and so forth, and therefore they're not really benefiting from this financial protection and so on and so forth. So Hosenpo mentions that unless you design these financing reforms with an equity-oriented approach, then you may actually move back away from universal health coverage. You may leave some people behind. So it's important for us to monitor whether we're actually leaving some people behind. And so that's the reason why this work was conducted by Edwin. So Edwin's my supervisor and colleagues. So they looked at the two known measures of financial protection. So looked at impoverishment and looked at incidence of catastrophic healthcare payments. And they used the Household Health Expenditure and Utilization Survey 2013 and found generally, you can access the paper, that about 4.5% incidence of catastrophic health expenditures as of 2013. Well, this is good news in a way because 2007 had found 14% incidence of catastrophe. So I can say that the incidence of catastrophe has reduced over the past 5 years. Whether to attribute that to the interventions that have been conducted in that period is a different story. This is a description only. And if we consider indirect costs, transport, and related cost to access these facilities, the catastrophe incidence comes to about 6%. So further to that, they went ahead and tried to look at what are the main explanatory. So what are the things that explain this catastrophe or that contribute to or that are associated with this catastrophe? And one of the main points that I thought to bring out here is socioeconomic status. That so you could see about the richest in that survey sample, the richest quintile had about 2% incidence of catastrophe, while the poorest at about 9.9% or 10%. So an odds ratio of about 5 of incurring catastrophic expenditure if you are in quintile 1 compared to the quintile 5. But then the question is, so yeah, we've reported a reduction in incidence of catastrophe, so should we celebrate? Is that all that we want to get? So here's a thought experiment, and you may find it actually interesting. So if you're not able to access healthcare, will you incur healthcare costs? If you are not able to access healthcare at all, so will you be able to measure how much you spent at the facility? None. So what are the chances that you will incur catastrophe? It's probably 0, right? Because you're not spending anything. So that's the problem with this instrument for measuring. It assumes that everybody is able to access healthcare and is able to actually get to the facility and access. So it's a measure that is good in places where you have high levels of service coverage, but it's a bit tricky when you actually have some people who are not accessing healthcare at all. So some work that's been going on right now is further to this, has been looking at what are the barriers to access amongst the people who are poorest in society. So went to demographic and health surveillance sites in the country. There's one in Kibera, conducted by APHRC. There's one in Kilifi with the Wellcome Trust. There's one in Siaya, I think by CDC. So some qualitative interviews targeting the poorest groups. So you actually arranged these people in these surveillance sites into quintiles and reached out to the poorest, to the 5th quintile, and try to figure out from them what are the barriers, what are the views that they have regarding the health financing reforms and regarding access to health services. And I'm just going to present 3 main views that we can just discuss later. And one is about availability. So you can see one of the comments that one of the individuals who was interviewed says that they go to the public health facilities because they don't have money. But when they get there, they find that the machines are not working. They're forced to go back home without receiving any care. So you realize that they actually they might not have spent. And so if you go quantitatively and find out how much have they spent on that visit, you might find that there's no much expenditure. But did they actually achieve the aim of that visit? So those are the things to consider when interpreting that. So look at another situation about affordability. So even though some of the poorest belong to financial protection schemes, so insurance coverage, health insurance subsidy for the poor, they also accessing free maternity services. Some facilities still charge extra costs that the poorest actually seem to suffer more because they're not able to raise these resources. So someone says, if care is supposed to be free, it should be free. But when you go to the clinic, it's written free outside, but when you get in there, you have to pay for something or the other. So that becomes a barrier. Okay. The other thing that happens is, now from the supply side, is since the facilities are not able to gather resources, then they lose autonomy. They are not able to make decisions that suit their population best. And so you find that sometimes some resources that they had before are not working anymore. So one of the individuals said that I was told that they don't have radiotherapy machines here, and I was told to go to a certain private hospital. And I heard that the cost is high. It's about 2,000 shillings to see a doctor, and you haven't even been treated yet. I don't have the ability to get that money. And how accessible